Shall I?
Yes, ma'am.
Yeah. Good evening. On behalf of Dr. Sharad Patina, the President TAPISAR, I welcome our faculty for this journal club, Dr. Madhuri ma'am, Dr. Vasundhara Jagannathan, Dr. Sujata Suresh, and Dr. Anantha Lakshmi, and the fellowship students, Dr. Vaishnavi and Dr. Smita from Madhuri ma'am's unit. So I request Dr. Sindhu to take over the session.
Thank you, ma'am. Good evening. Welcome to the Journal Club. Sahiti, can you move the slide, please? Next. Next. For the first session, I'd like to invite the chairperson, Dr. Vasundhara Jagannathan, who is the medical director at Sri Chakra Fertility and is an executive committee member of TAPISAR. Madam has done her undergraduation in Belgaum, and she's done her DGO from SRMC and RI and DNB from Apollo Hospitals. She has many awards to her credit and is a very active academician. Happy to have you here today, ma'am. I request you to introduce the expert and the speaker for today's clinical session.
Good evening, and thank you so much for giving this opportunity. I'm really grateful. At the outset, I take immense pleasure in introducing Dr. Madhuri Patil Madam for this Journal Club session of TAPISAR. She is the clinical director of Dr. Patil's Fertility and Endoscopic Clinic, Bangalore. She's associated editor of Fertility and Sterility, an official publication of ASRM. She is chairperson of Aspire SIG Group for Reproductive Endocrinology, President and founder member of Fertility Preservation Society of India, Vice President and founder member of the PCOS Society of India, Vice President, Indian Society of Assisted Reproduction, Board member of PCOS Society, Governing Council member of ICOG. She is the member Education and Accreditation Committee of Aspire and Aspire SIG Implantation, Associate Editor of the Onco-Fertility Journal, past Editor-in-Chief of JHRS, various awards to her credit. She's a well-known figure in the field of reproductive medicine, and we're indeed very humbled to have her here today for this journal club, and she's got various publications in national and international journals. We welcome you, ma'am. So today's topic will be dealt by Dr. Vaishnavi Priyamsha. She's going to discuss about the development and validation of a gonadotropin dose selection model for optimized ovarian stimulation in IVF-ICSI cycles. It is an IPD data analysis. It is an extremely important aspect. We all have gone through meta-analysis, but IPD meta-analysis is more robust, and it is a gold standard of systematic review, which gives us more validated and better results. So let us hear from Dr. Vaishnavi. And Dr. Vaishnavi is a current fellowship student of reproductive medicine at Dr. Patil's Fertility and Endoscopic Unit in Bengaluru. Over to you, Dr. Vaishnavi. We welcome you.
Good evening, respected seniors and everyone. I would like to share my screen now. Am I visible? Like, is my screen full screen?
Yeah,
No,
screen
you
is
put it on
visible.
full
Can you put it on slideshow?
No. That down, that button is there, na? Slideshow ka. You press on that.
Yes, ma'am.
Or you go to slideshow, na, here, and then you, yeah. No, you share the screen. Down, there's a button, na?
Yes, ma'am.
Yeah.
So today I'll be discussing about the gonadotropin dosage validation and prediction selection model for optimized ovarian stimulation in IVF and ICSI cycles. It is an individual participant data meta-analysis. The ovarian response to gonadotropin stimulation varies widely among women.
Are you having some problems, Dr. Vaishnavi?
1 second. And predict the probability of live birth as well as the treatment risks. Many studies have evaluated the impact of different gonadotropin starting doses, mainly based on predictive variables like ovarian reserve tests, anti-mullerian hormone (AFC) and basal follicle stimulating hormone. A Cochrane review systematic review revealed that individualizing the gonadotropin starting dose does not affect the efficacy in terms of ongoing pregnancy or live birth rates, but may reduce the treatment risks such as development of ovarian hyperstimulation syndrome. An individual patient data meta-analysis offers a unique opportunity to develop and validate a universal prediction model to help choose the optimal gonadotropin starting dose to minimize the treatment risks without compromising the efficacy. The objectives of this individual participation data meta-analysis is to develop and validate a gonadotropin dose selection model to guide the choice of the gonadotropin starting dose in IVF and ICSI cycles with the purpose of minimizing the treatment risks without compromising the live birth rates. Methods and materials used, the electronic databases including Medline and Embase and CRSO were searched to identify the eligible studies. The last search was performed on 13 July in 2022. Randomized control trials were included if they compared different doses of gonadotropins in women undergoing IVF and ICSI cycles and presented with at least one type of ovarian reserve test and reported one live birth or any ongoing pregnancy. All the authors of eligible studies were contacted to share the individual participation data. The individual participation data and information within the publications were used to determine the risk of bias. Then generalized linear mixed multi-level models were applied for predictor selection and model development. Variable selection stage, first the internal and external cross-validation sets were made to select the predictors. Then later the model development stage, different combinations with the most predictive variables from variable selection stage were used in model development. The forest plots of performance measures were used and summary statistics calculated, resulting in summary area under curve, summary calibration slope, and summary calibration in large per model. A model that is easy to adopt into routine practice patient care with less variables that are easy to obtain and with highest performance was developed as a clinically feasible model. The data was included from a total of 4 randomized control trials with the data of 3,455 patients were included. After extensive modeling, women aged above 39 years and over were excluded, which resulted definitive inclusion of 2,907 women. Various variable predictors were made: the age and BMI, antral follicular count, AMH, basal follicular stimulating hormone levels, starting doses, duration subfertility in months, cycle length in days, and number of stimulation cycles, total gonadotropin dose in international units, number of oocytes and number of usable embryos, and number of cryopreserved embryos, all taken as variables. Then the model development stage, the internal external validation was done. An optimal model for live birth, which shows the forest plots of performance measures were used. The summary statistics were calculated using random effect meta-analysis estimate. The selected optimal predictor model for live birth included predictors, age, starting dose, BMI, antral follicular count, or IVF or ICSI cycle, and AMH. The summary statistic results in an area under curve of 0.557, which was classified as poor to discriminate between women with and without a live birth. Coming to the clinically feasible model, the area under the overall area under the curve was 0.554 with 95% confidence interval from 0.530 to 0.578, which is also classified as poor to discriminate between the women with normal, with or without a live birth. Coming to the combined treatment risks, 2 models were selected as optimal models for combined treatment risks as the performance were equal. The model 1, this included predictors such as age, starting dose, AMH, and basal follicle stimulating hormone levels. The overall area under curve comes to 0.769, which is classified as acceptable to discriminate between women with and without the combined treatment risk event. Coming to the second optimal model. The forest plot of the area under curve is 0.769 with the confidence limit of 0.729 to 0.809, which is classified as acceptable to discriminate between the women with and without combined treatment risk event. A clinically feasible model, predictors including age, starting dose, AMH, and GNR analogs were included. The area under curve was 0.748, which is also classified as acceptable to discriminate women with and without the combined treatment risk events. These are examples of FSH dose calculator. The first one was using the GnRH antagonist protocol with AMH level of 5.3 micrograms per liter. In this, as we can see, the patient has increased treatment risk with the gonadotropin starting dose. If the risk of 3% was considered okay, acceptable in clinical practice, then the starting dose would be 137.5 international units of follicular stimulating hormone. The second example of FSH dose calculator is in GnRH agonist protocol with AMH level of 5.3 microgram per liter. Even in this, if the treatment risk was taken as 3%, then the patient is advised to start with 100 units of follicular stimulating hormone. Coming to the strengths of the study, this is the largest collaboration on the dose prediction and first to combine the live birth rate and dose selection in one prediction model for various FSH preparations. This model is validated in different geographical and temporal situations. This provided with possibility to adjust the dose selection model to clinic's characteristics, that is the mean age and mean starting dose. Coming to the limitations, as the intention to treat analysis was used, an underestimation of outcome events may have occurred. The live birth rate was chosen as one of the main outcomes, but the cumulative birth rate was unfortunately not provided by many studies, which were included in this. The aim of the study was to create a model including patient characteristics whereby gonadotropin starting dose was predictive of both live birth and the treatment risks. But the model performed poorly on predicting live birth by modifying the starting dose. On contrary, the predicting treatment risks in terms of OHS occurrence and management by modifying gonadotropin starting dose was adequate. This dose selection model, consisting of easily obtainable patient characteristics, aids in the choice of optimal gonadotropin starting dose for each individual patient to lower the treatment risks and potentially reduce the treatment costs. Up until recently, the clinicians had to select a dose based on their own subjective experience and interpretation of predictive parameters like age, ovarian reserve tests, BMI, and etc. Over the last years, different algorithms have been developed that can be used to calculate gonadotropin starting dose with intent to optimize the reproductive outcome and reduce the risks of ovarian hyperstimulation syndrome. For folitropin delta, due to unique pharmacokinetic and dynamic profile, a comparable dosing strategy is developed as it cannot be compared with other gonadotropin preparations. Therefore, a new model developed, an optimal model that has more stable predictions in different settings and a clinically feasible model which is easy to use in clinical practice. This dose selection model should, however, be evaluated in clinical practice to confirm if it aids the clinician to choose an appropriate starting dose. The clinical acceptability of this model is currently being evaluated after implementation in two study centers in Netherlands. In a similar study, 313 consecutive women undergoing 2 successive IVF cycles attempt were evaluated. Using the logistic regression model, 2 equations were developed using the patient level data to determine the daily dosage needed, aiming to increase the oocyte yield in successive cycles. In step 1, they need to calculate the X by using the following formula, and the A1 was 1 and A2 was 0 if the oocytes retrieved in the first cycle were less than 7, less than or equal to 7. And A1 is 0 and A2 is 1 if the oocyte retrieved in first cycle is between 8 and 12. And if it is more than 13, the A1 is 0 and the A2 is 0. So after coming to the value of X, then we need to incorporate in this formula. And if P is more than 5, 0.5, then suggested daily gonadotropin dose in successive cycles should be 450 international units. While if P is less than 0.5, it should be 300 international units. Conclusion, using the aforementioned equation, succeeded in determining the daily gonadotropin dose that might result in increasing oocyte yield with area under cover of 0.85. In another similar study, which is a non-linear relationship between gonadotropin total dose applied and live birth rates in non-PCO patients, which is a retrospective cohort study. The purpose of this was to explore relationship between the total dose of FSH applied during controlled ovarian stimulation and the live birth rates in non-PCOS population. Many studies have found no difference between the dose of FSH and the pregnancy outcomes. However, a recent large retrospective study found a negative correlation between the live birth rates and increasing doses of FSH. Coming to the conclusion, this dose selection model, consisting of easily obtainable objective patient characteristics, may aid in choosing optimal gonadotropin alpha or beta stimulation doses for each individual patient to minimize the treatment risks while maintaining the effectiveness and could potentially reduce the patient burden and treatment costs. Thank you.
Then stop sharing your slides.
Yes, ma'am.
Yes, Vasundhara, you can go.
Thank you, Dr. Vaishnavi. It is a nice presentation. In fact, it is giving us more insights on how to do gonadotropin calculation, especially starting dose. But then we have to have more robust studies across the responders, normal, poor, and hyper responders. And also, we have to look at some model wherein we have one cycle and done all. That means the patient's cumulative live birth rate should be good at the end of one cycle. So definitely the risk factors, it is a very robust study that, risk of OHSS and other things, but live birth rates, I think still we need more data to, and better formulas and more preparations like polytropin delta is also going to come up. So we need to have different predictors into starting dose. Still, I think right now, the ground thing is we're using the AFC, AMH, and, we are individualizing patients' dosage based on that. However, this particular formula which you shared last is quite interesting, and we can see more studies on that. I would request Madhuri Madam to share her views as well.
So if you look at the clinical prediction model, like the AUC was just 0.5. So basically it has very poor discrimination. So basically it does not have any statistical significance. And when you also take the other two models, the optimal model 1 and 2, again, the AUC was just 0.769 and almost similar. So if you have even that type of area under the curve, again, it only has a fair discrimination. So I think we require further randomized control trials, and probably we need to look at the other factors also that are involved, to really predict the starting dose. So what we normally do is, which is basically based on the AMH, antral follicular count, as well as the BMI and the age. So definitely we take into account what normally we use in our clinical practice. But these models probably said that we require lesser number of parameters, to calculate the dose. But I think we require more studies to really come out with what the starting dose should be, because there were many studies even earlier which were published by Namaka and the others, which they also took into account. It is basically the age, antral follicular count, and the AMH values. So I think we have to further investigate this model to really see what the starting dose was. And I would just like to mention over here that Dr. Naina Patel, she is using some opt IVF where they have developed a AI-based model on calculation of the starting dose. So this is basically, I don't know the intricacies of it, but I had heard a talk which was given by her where they looked at the follicular diameter on day 1 and on day 5 of stimulation. And depending on that, they had a AI calculation which was done, and that's how they calculated the dose. So I think I must talk once to her and really understand how they did it, because I just heard her speak once on that. So I think we should, I should, I never then got back to her to ask her how really they did it. But this was their AI prediction model used the follicular sizes on day 1 and day 5, and they calculated the AI dose. And they found that this prediction model was much better than which is based on our clinical and investigative models. And they
What is your starting dose and how do you calculate it, ma'am? The maximum dose, gonadotrophins.
maximum dose, normally I in a PCOS patient, my starting dose is anywhere between 100 to 150. If I have a normal responders, I normally would give 225. In a poor responder, I give 300. But if the AMH is very low, if it's less than 1 or something, then I would definitely give 450. But I don't give anything more than 450 in my practice. And then poor responders, I tend to use a combination of both recombinant FSH as well as HMG.
And also,
Ma'am,
ma'am,
when you have an AMH of more than 9, as you said in PCOs, you start with 100 or 150.
So if it
Sometimes
is
I feel they don't
higher,
respond at all.
so these patients who have if they have a AMH anywhere between 3.5 to 6 or 7, then probably they are at a risk of hyperstimulation. So I would just start with either 100 or 150, depending on her BMI. So if her BMI is high, I would start with 150, but if it's low, I would start with 100. But if I have a patient whose BMI is more than, whose AMH values are more than 9 or 10, then here I would also use a combination of LH, because in my practice, I have seen that these patients are poor responders in the PCOS group. And this is because we know that AMH basically inhibits the recruitment of the preantral to antral follicles, and it also inhibits the action of the cytochrome enzyme, and therefore conversion of androstenedione to estradiol, and also decreases the action of FSH at the follicular level. So in these patients, I would definitely start with probably a slightly higher dose, but I would definitely also add an LH activity. So I would probably give 125 of recombinant FSH and 75 of HMG.
and there is a
Dr.
segment
Madhuri,
of these,
Dr. Asha Rao here.
Yeah. Tell me.
Yeah, I do have a doubt about this PCO and the dosage. I feel the dosage that you said was apt in the days of GnRH agonist cycles. We were much worried and we would start with this dose, 100 and 150
Yeah,
for
but I
PCO.
don't.
But
I
for
don't.
antagonists, if you use that, sometimes it's not sufficient.
No, I don't do I don't do a freeze-all cycle for all my patients. So what I prefer is I prefer getting about 8 to 10 or at the most 12 follicles, even in my PCOS patients, because I'm of a saying that we should not just think of the live birth rate, we should also think of about the child later, because there are not many studies published. Now there are many studies which are coming where they say that frozen cycles, I mean, apart from the clinical complications, they increase. There are always some amount of epigenetic changes which happens in the embryo because of freezing and thawing. And therefore, my principle, at least in my practice, is that I don't do freeze-all unless really indicated and when the patient is going to go for hyperstimulation, which is quite less, I think, in the last about 10 years after we've started using antagonists. And I always use a lower dose because I don't desire more than 12 to 14 follicles.
And when you say it's a fresh cycle, do you check the progesterones on the day of HCG before you go ahead with the fresh transfer?
So actually, my principle is on day, once I start my stimulation on day 4, I normally will do my E2 levels, because depending on my E2 levels, I will decide when I need to start the antagonist. So if I find on day 4 itself, my E2 levels are 250, then I would prefer starting either on that day or I'd start on the next day. But if I see that they're less than 200, then I'll wait, and then probably I'll start on day 6. I don't wait for, I don't do a flexible protocol where I start my antagonist on after 14 millimeters of diameter. I always do a E2 and P4 level before I give a trigger. And usually because I start my antagonist probably early, I mean, I don't usually have, and also would do a progesterone level before I do the embryo transfer, because then that will, because I normally use only one progesterone unless the progesterone levels are really low. And if I'm using a vaginal progesterone, if they're less than 15, then I would add another progesterone. Or if I'm using an intramuscular progesterone, usually then the levels are between 30 to 40. So if they are less than 25 with an intramuscular progesterone, I would then add another progesterone.
Dr. Madhuri, if the progesterone is higher on the day of trigger, will you be going in for frozen embryo cycles?
It depends. If it's a poor responder, the patient is a poor responder, and if the levels are more than 0.8, then I would go. If it's a normal responder, even if it's still 1.25, I would do an embryo. I would do a fresh embryo transfer. In PCOS patients, if I find that they have too many follicles and yeah, the E2 level is about 2,500. Many a times the progesterone can be more higher because the levels of progesterone basically depend upon the number of follicles that are growing. And as we all know that normally there is some amount of progesterone rise before, before ovulation, normal in a normal cycle before the LH, along with the LH surge. But there are several studies which have been published. They say the cutoff level in a PCOS patient for progesterone level just before your trigger is about 2 to 2.25 nanograms.
Nanograms.
Ma'am, if you're contemplating a fresh transfer in PCO patients, so what kind of luteal support? Like you give them a dual trigger and then you give a HCG 1500 and progesterone, or what do you do, ma'am? You follow
if I've given a GnRH agonist trigger, I normally only would add Proganova, and I don't give HCG as a luteal support in my PCOS patients. And in those patients where I find that the E2 is more than 2,200 to 2,500, and if you've got more follicles, I would add Proganova, because in these follicles, the E2 levels fall more steeply, because when you're aspirating, you're removing quite a bit of granulosa cells, and therefore the E2 levels normally fall. So basically, your estrogen support is required only in those patients who have a high E2 level before your trigger. Because in these patients, you'll have a sudden drop of the E2 levels, whereas in other patients, probably you don't require E2 levels. In my poor responders, I also give HCG as along with the progesterone for luteal phase support, because there's some evidence that says that it helps. But in mostly normal responders and PCOS, I won't give. I just give one progesterone. And only if my progesterone levels on the day of embryo transfer suggest that the progesterone is low, I would add another progesterone. I don't use any drugs normally.
It's very encouraging to know that you're doing fresh transfers in PCOS, because none of us, at least I don't have the guts to do fresh transfer in PCOS. So it's really encouraging to know that you're doing that, ma'am, and we would take some
I have several pregnancies, even if I've given a GnRH agonist trigger.
Yeah.
I do have pregnancies because I normally would do a blastocyst and a single embryo transfer. And they really do not develop even late on.
Ma'am,
in general, Dr. Madhuri, the pregnancy rates after a GnRH trigger, in my experience, are much less. When I did it earlier, it was definitely less. So we had to give up fresh transfers in the GnRH trigger cycle.
Data, but my pregnancy rate is around 40% in these patients. Suppose it's about 50% with HCG trigger. It would be anywhere between 35 to 40% in those where I've given GnRH agonist trigger.
Do you check your LH?
Pardon? No, if I have to check whether the GnRH agonist has acted or not, 12 hours later, I do a LH and a progesterone level, because both of them, the LH level has to be more than 14 to 15. And the progesterone also should have risen from what it is in the pre-ovulatory.
Ma'am, in line with this topic of this journal club, I would just wanted to, say that sometimes in PCO patients, we do face receptor polymorphisms, and we have encountered, poor response in the previous cycle. So
So
based on
therefore,
that,
in these patients, LS is very important. LS
important. Yes, ma'am.
very important. So therefore, normally, most of the times, these patients, I would have done 1 or 2 cycles because these patients don't have any other pathology. So I would have done IUI cycles with gonadotropin. So I would know how they respond. And depending on that, I would then start my...
The starting dose. So again, I also had an opportunity to just read a recent article which was comparing the PPOS protocol with our antagonist protocol, and they were finding out the starting dose, whether it is any different when we are using that. And they were saying it is comparable, and though 1 or 2 days of extra gonadotropins may be required, but the number of oocytes retrieved and everything
It
was
doesn't
similar.
really make a difference. Yes. The PPOS protocol does not. So for sure, if you're going to go for oocyte freezing, I think PPOS protocol is good enough because it is also going to reduce the cost of your treatment because we know our antagonists are quite expensive. And in patients, and for fertility preservation also, especially in patients with endometrial cancer, a PPOS protocol is good enough.
Thank you, ma'am.
Thank you,
There are
ma'am.
a couple
Thank
of
you.
questions in the chat box. I think the
Yeah.
first two have been answered. The last one is it possible for a vaginal progesterone to reflect good value in the serum? Is there any time to measure the progesterone?
No, that's what I said. Now, when normally it's now a norm that before you do an embryo transfer, especially a blastocyst transfer, either on day 4 or on in the morning of your transfer, you do the progesterone levels. If you're using a vaginal progesterone, your level should be at least 20. If you're using an intramuscular progesterone, it has to be more than 30 or 40 because the intramuscular progesterone usually has a higher level. So if it is anything less than that, probably you need to add another progesterone. And if you're giving only dydrogesterone 10 milligram 3 times a day, that cannot be measured in the blood. And therefore, there is no value of measuring progesterone level in blood if dydrogesterone is given for luteal phase support.
Thank you, ma'am.
We move to the next session.
So thank you, Madhuri ma'am. With the
There's one
let's move on to
question
the
from Radha. Is asking
How to correlate progesterone when there is a corpus luteum?
no, but corpus luteum will be there only when you're doing a normal ART cycle, no? You'll have multiple corpus lutea will be there, no? But many a times your corpus lutea do not function well because you have aspirated the granulosa cells. As against in a natural cycle wherein you're not aspirating. So all the granulosa and the theca cells are going to form the theca lutein cells and they're going to secrete progesterone. But it does not happen in an ART cycle because you are aspirating along with your oocyte, you aspirate your granulosa cells as well as some amount of theca cells. And therefore, it is your luteal support which is going to basically give you the value.
She's talking probably about FET cycles when you're giving
I think the
stimulated.
madam had already mentioned about progesterone at trigger levels of various responders. So I think we should take that cutoff and decide whether you want to do a fresh or frozen transfer.
No, she's talking about, I think if I'm not mistaken, the FET, if you have a corpus luteum and the progesterone levels. Am I right, Radha?
When they're doing an FET also, we are going to have a single, we are going to have a single corpus luteum. And so normally, luteal phase support is not required when you're doing a natural cycle or a ovulation induction cycle, frozen embryo transfer. So you can just measure the progesterone levels the day before your transfer. And if you find they're low, you add a progesterone. But we possibly empirically, we also give more amount of progesterone just for our satisfaction and for patient satisfaction.
Absolutely, yes.
Thank you, ma'am. We'll move on to the next session, ma'am. For the next session, I'd like to invite the chairperson, Dr. Sujata Suresh. She's the scientific head and senior embryologist at Vamsam Fertility Research Center, Coimbatore, Trichy, Tirunelveli, Arakonam, and Chennai. Madam is a certified clinical embryologist by ESHRE, and she's certified by at Kovai Medical Center and Hospital. And she's done her advanced embryology course at Parkway East Hospital, Singapore, and teaching faculty at Vamsam Fertility Research Center. She's done many projects guided in collaboration with DBT, and she's awarded the Young Rising Star Award 2023 by ISAR, and she is a life member of IFS, ISAR, ACE, and ESHRE, which has conducted many infertility workshops and given many lectures in national conferences. Ma'am, I welcome you, and I request you to introduce the expert and the speaker for today.
Yeah, good evening, everyone. Let's move on to the next session. Thank you, Dr. Sindhuja, for this kind introduction. I welcome and invite Dr. Ananta Lakshmi, who's the senior embryologist at Janani Fertility Center, Trichy. And she is an ESHRE certified senior clinical embryologist and certified also by the American College of Embryology and IFS certified clinical embryology. And she has more awards on her credit like ISAR Manish Bankar Young Achievers Award and IFS Young Achievers Award and Embryologist of the Month by American College of Embryology and ISAR Rising Star Award and Budding Embryologist of the Year National Fertility Awards by Economic Times. Warm welcome, Dr. Ananta Lakshmi. And let me introduce today's speaker, Dr. Smita, who's doing her fellowship in reproductive medicine at Dr. Patel's Fertility and Endoscopic Clinic, Bengaluru. Moving on to the journal presentation today, stating which is a recent paper which is published in Fertility Sterility this March 2025, where there has been discussing about the success rates with PGTA in good prognosis patient are dependent on age. So over to you, Dr. Smita.
Yes, ma'am. I'll just share my screen. Is my screen visible, ma'am?
Yes, please.
Good evening, respected seniors and all my colleagues. I'm Dr. Smita Kadapa, and I thank you very much for this opportunity to be a part of this journal club today. The article for today's discussion that we've chosen is Success Rates with Pre-Implantation Genetic Testing for Aneuploidy in Good Prognosis Patients are Dependent on Age. This was published by Benjamin S. Harris et al. In Fertility and Sterility Journal, Volume 123 in March of 2025. So, aneuploidy is the most common cause of miscarriage, and it represents, just one second. Representing 50 to 70% of cases. The risk of oocyte aneuploidy increases with maternal age, with increasing likelihood of aneuploidy in age more than 35 years, which adversely affects the rates of live birth and increases the miscarriage rates. Pre-implantation genetic testing for aneuploidy, that is PGTA, during IVF is used to evaluate embryos for aneuploidy and identify the chromosomally balanced, that is euploid embryos for transfer. The goal of PGTA is to maximize the live birth rate per embryo transferred while minimizing the rates of miscarriage and multiple pregnancy via single embryo transfer. Despite significant advances in PGT, including the application of next generation sequencing or NGS, the benefit of PGTA in improving the live birth rates remains controversial. NGS is the most accurate iteration of PGTA with a sensitivity and specificity approaching 100% and a clinical error rate of 0.7% per embryo. The objective of the study was to evaluate the cumulative live birth rate after PGTA with NGS compared with morphology alone among good prognosis patients aged 21 to 40 years undergoing single blastocyst transfer. The hypothesis tested was PGTA cycles do not have improved cumulative live birth compared with non-PGT cycles. The study design, it was a retrospective cohort study using the Society for Assisted Reproductive Technology Clinical Outcome Reporting System, the SART course. The subjects included patients aged 21 to 40 years who were undergoing first autologous retrieval cycles, which resulted in more than or equal to 5 fertilized oocytes with subsequent single blastocyst transfer in Society for Assisted Reproductive Technology clinics in the period of 2016 to 2019. The exclusion criteria: cycles with patients aged more than 40 years, total number of fertilized oocytes less than 5, pre-implantation genetic testing for reasons other than aneuploidy, thawed oocytes, embryo banking, use of gestational carrier, cleavage stage embryos, mixed embryos from multiple stimulation cycles, and cycles labeled as the PGD some embryos or PGD unknown, and in cases of recurrent pregnancy loss. The data was obtained from the SART course through voluntary submission, and it was reported to the Centers for Disease Control and Prevention as per their protocol. The outcome measures were: the primary outcome was cumulative live birth, and the secondary outcomes included clinical pregnancy, miscarriage, multiple birth, and perinatal mortality per transfer. The important definitions in the study are: the cumulative live birth, at least one live birth achieved after 1, 2, or up to 3 single blastocyst transfers for each retrieval cycle. This was only included once in the numerator. Cycles using PGTA that did not have embryos available for transfer, most likely because of no euploid embryos, were included in the analysis as having no cumulative live birth. The patient and retrieval cycle characteristics were described as mean for continuous variables or as frequency for categorical variables. A modified Poisson regression model was used to evaluate the overall association between PGTA and cumulative live birth, adjusting for covariates per retrieval per individual. A separate modified Poisson regression model included PGTA age groups and their interaction to assess the association between PGTA and cumulative live birth by age group. So risk ratio, that is RR, and 95% confidence intervals were reported from all regression models, and the significance value was fixed at 0.05. Any risk ratio more than 1 was considered as significant. The table 1 details a creation of the analysis data set based on inclusion or exclusion criteria. So a total of 56,469 retrieval cycles were included. 70.5% of women were aged less than 35, 20.5% women were aged 35 to 37, and 9.1% women were aged 38 to 40 years at retrieval cycle. The mean age at retrieval was 32.4 years with a standard deviation of 3.7. The mean BMI was 26.4 kg per meter square. Most patients were nulliparous, non-smokers, and non-Hispanic white. The significant point is use of PGTA was higher in older age groups at the time of retrieval cycle. So it was 4.1%, 20.8%, and 55% respectively among the ages of less than 35, 35 to 37, and 38 to 40 years. So this is the table which outlines the patient characteristics by age at retrieval and PGTA usage. The covariates, the age was divided, as I mentioned, less than 35, 35 to 37, and 38 to 40. The covariates were fixed a priori, that was BMI, the nulliparity, smoking status, race or ethnicity, and the fertility factors, the infertility diagnosis, that is unexplained male infertility, endometriosis, diminished ovarian reserve, PCOS, tubal factors, uterine, and other factors. This table shows the outcomes stratified by age at retrieval and PGTA usage. So the average number of fertilized oocytes, the blastocysts, and embryos frozen were similar between the PGTA and non-PGTA cycles. In this cohort, the proportion of cumulative live birth was lower among those who used PGTA, that is 59.1%, than those who did not use PGTA, that is 65.7%. But when stratified by age, the proportion of cumulative live birth was 67.3% versus 68.6% in the PGTA versus no PGTA groups respectively in those aged less than 35 years. The cumulative live birth in the PGTA group was higher than the no PGTA group. The outcomes of individual transfer cycles were similar between the PGTA and no PGTA groups among individuals aged less than 35 years. Among those aged more than 35 years using PGTA, there were higher proportions of clinical pregnancy. In the 35 to 37 years, it was 64.8% versus 54.5%. In 38 to 40 years, it was 63.3% versus 46.4%. And live birth was also higher. That is, in 35 to 37 years, it was 50.5.1 versus 43%. And in 38 to 48 years, it was 40 years, it was 54.3 versus 33.7% compared with no PGTA. Clinical pregnancy, miscarriage, and live birth among individuals aged less than 35 years who used PGTA were not significantly different from those in their age group who did not use PGTA testing. So clinical pregnancies were 16% and 32% more likely in those aged 35 to 37 and 38 to 40 years respectively who used PGTA compared with no PGTA. Miscarriages were 29% and 48% less likely in those aged 35 to 37 and 38 to 40 years respectively who used PGTA compared with those who did not. Among individuals aged 35 to 37 and 38 to 40 years, those who used PGTA were 24% and 55% more likely to have a live birth than those who did not. Individuals who used PGTA were 3% more likely to have cumulative live birth than those who did not use PGTA. In individuals aged less than 35 years who use PGTA testing, 4% were less likely to have cumulative live birth than those who did not use PGTA. Those using PGTA were more likely to have cumulative live birth than those who did not in cycles for patients aged 35 to 37 years and those aged 38 to 40 years. There was a subgroup analysis done using only frozen single blastocyst transfer, and this slide shows the results. This subgroup analysis included 38,052 transfers. The characteristics of the individuals in the subgroup analysis were similar to those in the primary analysis. The average number of fertilized oocytes, blastocysts, and embryos frozen were lower in the PGTA than non-PGTA cycles. In the overall cohort, the proportion of cumulative live birth was lower in individuals who used PGTA, 59.1%, than those who did not, 61.8%. So this is the results of freeze-all cycles with frozen single blastocyst transfers. Among those aged less than 35 years, the proportion of cumulative live birth was 67.3% in the PGTA group compared with 64.8% in the no PGTA group. In the older age groups, the cumulative live birth in PGTA group was higher. That was 62.5% versus 54% in ages 35 to 37 years and 51.3% versus 38.7% in age 38 to 40 years. After adjusting for covariates, the cumulative live birth was 11% more likely in those who used PGTA compared with those without PGTA. And when stratified by age group, patients using PGTA were significantly more likely to have cumulative live birth compared with no PGTA among individuals aged more than or equal to 35 years. There was no significant association between PGTA and cumulative live birth among individuals aged less than 35 years at retrieval. And in the older age groups, there were higher proportions of clinical pregnancy and live birth. The clinical question of this study has been studied extensively in recent years. A similar retrospective cohort study using the SATCORS database from 2014 to 2016 demonstrated significantly reduced cumulative live birth in all age groups with PGTA, except in women aged more than 40 years. The STAR trial, which was a randomized clinical trial, demonstrated a statistically significant decrease in live birth rate with PGTA in women aged less than 35 years. PGTA did improve the rates of live birth per transfer among women aged 35 to 40 years. However, the results were not significant after an intention to treat analysis. In contrast, a recent retrospective cohort study from the UK demonstrated a significantly high live birth rate per embryo transferred with PGTA. The ASRM and the SART committee opinion on the use of pre-implantation genetic testing for aneuploidy, which was published in September 2024, had the following conclusions. The value of PGTA as a universal screening test for all patients undergoing IVF has not been demonstrated. Two recent multicenter RCTs in women with available blastocysts have shown that overall pregnancy outcomes via FET were similar between conventional IVF versus PGTA. The value of PGTA to lower the risk of clinical miscarriage is also unclear. However, these studies have important limitations, and further research is needed to analyze cost effectiveness, use of mosaic embryos, false positive results, risk of embryo damage during PGTA, time to pregnancy, utility in specific subgroups like recurrent pregnancy loss and advanced maternal age, use of sex selection, and total reproductive potential per intervention. So they concluded that at present, the routine use of PGTA in all patients undergoing IVF treatment cannot be recommended. The strengths of this study is that it was a recent study, 2016 to 2019 data from SATCORS, which was a large national database of ERT programs was used. This increased the generalizability and external validity of the study. The analysis was limited to single blastocyst transfers, which is reflective of current clinical practice. And all cycles used the next generation sequencing based PGTA to reflect current laboratory technology. Patients with embryos that underwent PGTA but did not have embryo transfer were also included in the analysis. It had various limitations. It was not a prospective randomized clinical trial, and the retrospective study design could be subject to confounding and can identify associations but not causation. Laboratory practices are not standardized across the SART clinics. One major methodological assumption made was PGTA cycles where no embryo was transferred were because of lack of euploid embryos available. The dataset did not include information regarding whether an embryo was euploid, aneuploid, or mosaic, and cycles in which multiple embryos were transferred were excluded. Patients with small number of fertilized eggs were excluded. Hence, conclusions may not apply to the low responders of the general population with IVF. Regarding lower success rates among those aged less than 35 years, the findings could reflect damage associated with biopsy of an otherwise normal embryo, and PGTA decreases the number of usable blastocysts, which inherently contributes to lower cumulative live birth rates. So in conclusion, in this large national database, success rates in cycles using PGTA were dependent on age. The cumulative live birth was observed to be significantly less likely in PGTA cycles among those aged less than 35 years and more likely among those aged 38 to 40 years compared with no PGTA. In individuals with no fresh transfer, the use of PGTA was associated with higher likelihood of cumulative live birth in those aged 35 to 40 years, and no significant association was seen in those aged less than 35 years with or without PGTA. Miscarriage was significantly less likely with PGTA among those aged 35 to 40 years in a subgroup analysis of freeze-all cycles. In a time-limited study such as this, PGTA may be expected to identify the usable blastocysts in specific populations and to shorten the time to live birth in patients with higher odds of aneuploidy per embryo transfer, that is, elderly patients. And based on these findings, patients should be counseled that PGTA may be beneficial for those aged more than or equal to 35 years. Thank you so much for this opportunity and a patient listening.
Thank you, Dr. Smita. It was a nice and clear presentation. So as we all know that the main cause for the fertility, like the pregnancy failure and miscarriage is aneuploidy, and most of the spontaneous abortions is due to the mitotic errors which is occurring in the early embryo development and the meiotic errors which is huge, drastically high with the advanced maternal age. So despite the fact that the PGTA application has been employed with around almost 20 years, still now there is ongoing controversy regarding its effectiveness. So I would like to just ask the expert opinion about, is PGTA an effective? If yes, then which subsets of patients are beneficial, and if no, then why? Dr. Anantalakshmi.
Thank you so much. Dr. Sujata, as you pointed out rightly, the meiotic errors are more common in advanced age group. But as concluded by this study also, my opinion is also in concurrence with that conclusion. PGT is not universally applicable technique where you can advise all the patients. For example, advanced maternal age more than 35, you have to undergo PGT. It is not so. In our ART law itself, it states that it should be done only for the indicated cases. So coming to the indication, what are the indications as such? At present, I feel there is no such indication. Sorry to say this. For example, we can say the advanced maternal age, for example, more than 38 years or 40 years. If they come with that, first of all, we should counsel the patient regarding the pros and cons of PGT. How many embryos you want to get a euploid embryo in that age group. That should be counseled to the patient. After counseling about the cost and the number of embryos for getting a single euploid embryo, if the patient is having good reserve, then it is fine. Same way, if she is having low reserve, we have to pull up the embryos for biopsy itself. So again, it adds on to the cost. So all these things taking into consideration, after a proper counseling, if the patient is wishes to take that procedure, we can proceed. Otherwise, from the clinical side or the clinician side, we should not insist the same on the patient as a good technique or the established technique like that. And coming to the point that in this article itself, it is mentioned that NGS has 100% sensitivity almost. So the clinical error rate is almost 0.7%. Just I want to mention a point on that. When we are taking the reference which is quoted by this article, just they have mentioned that they have compared the NGS with other techniques like array CGH and so. they just mentioned that NGS is comparable with when the embryo is tested for aneuploidy using NGS, that is group is separate, and they have applied same NGS for products of conception or amniocentesis, that is separate. So they have compared that whether this is giving an accurate result or not. So the PGT from the embryo and the products of conception has been tested using NGS. So both in concordance they have reported, and using that data they have mentioned that it is giving 100% specificity. So I am not for that. So, and one more thing is number of cells we are testing. So even in blastocyst, we are testing around 5 to 7 trophoectoderm cells, or up to 8. So taking a small number of cells and coating that too from trophoectoderm, we are not very good enough to say that this embryo is euploid or aneuploid. And again, one thing, oocyte can also correct the embryo, can go autocorrection during implantation. And we have so many studies reporting that even after transferring aneuploidy embryos, that reported in live birth. So there are studies, when you take literature evidence, there are studies for and against PGT. So as a clinician and embryologist, we should be well educated about the pros and cons of the technique, and then only we should counsel the patient.
So as you said, there are so many single-centric and a cohort of retrospective studies in favor of this PGTA in AMA, but there are very few RCTs, and even some clinics wants to wait for more convincing evidence. So if we are going to do PGTA, what is the thing you want to elaborate about the counseling part to the patient? About mosaicism, the false positive, the no result criteria, the concerns. Like, can you just elaborate on what is very important to document?
Actually, from our side, we should not impose the technique onto the patient, first of all. If nowadays so many patients are very educated and they come to us asking about this technique. So for that particular patients, I recommend that cost is the first thing. Whether they are affordable for so many cycles to pull up the embryos, even in single cycle, they get multiple embryos. For testing each embryos, it is going to be cost so much. So one thing is the cost. The second thing is going to be the number of embryos they need. For example, if they get a, for example, 38 years or 40 years patient, low reserve, we are going to get only 5 oocytes. We are going to do blastocyst biopsy. The 5 may not become blastocyst, or a single may become, or no blastocyst can be as a result. So that should be counseled to the patient, number of embryos required. And the third thing is about the results, test results. Better to have a genetic counselor always with you to counsel about the results. So many of the clinics doing PGTA lack genetic counseling properly. Either it will be done by the clinician or the embryologist. That should not happen. That should be done by a proper genetic counselor who is well educated about the reports. And another thing, the concordance rate, the sensitivity and specificity of the test should be well explained to the patient. So even in our IVF itself, regarding the success rate, we should have an informed consent regarding our success rate, right? We cannot claim that it is about 80% or 90%. So universal success rate should be mentioned in the return informed consent, and that should be given to the patient. Similarly, for PGTA, you have to mention all this. We are talking everything about return informed consent, but I don't know how many of the clinics follow that. Somebody will give the paper and they will ask the patient to sign that, and that is not actually right to do with. So we have to explain each and line mentioned in that paper and get it signed about the pros and cons like this. Another thing, if you are getting mosaic embryos or aneuploidy, there are so many people who is counseling the patient to have another cycle. Even I have seen a patient with 16 blastocysts, 16 oocytes, out of which they got only 3 blastocysts. All the 3 resulted in aneuploidy for just a 32-year-old patient. So first of all, why they have subjected that 32-year-old patient for PGT? That itself we don't know. So if the patient asks, you have to tell all these things. And if all the three embryos are going to be aneuploidy or mosaicism, what are you going to transfer? So that cannot be left with the patient. So the technical decisions has to be made by the embryologist or the clinician. So we have to explain all this in detail before the patient goes for an IVF cycle, proceed with an IVF cycle with PGT.
Yeah, so basically we can also have false positive and false negative. So you can have abnormal trophoectoderm but a normal inner cell mass, or you can have a normal trophoectoderm and an abnormal inner cell mass. So therefore, again, PGTA I think is a big question, and therefore probably doing for structural anomalies and for
I'm for PGTM and SR.
yeah,
That is
yes,
definitely useful.
and for monogenetic diseases probably is really indicated in all patients. Then one must also realize that in India, in our Indian population, as we know that we age more much earlier than the Caucasian population. So the number of oocytes and the embryos what we get after 35 years is significantly less. So then also we need to think whether we should waste those embryos of whatever chance she has, or just do PGT and discard all the embryos. Because I've seen so many people, they have only 3 or 2 blastocysts they do, and they say, no, it's abnormal, and they discard. So the patient goes without an embryo transfer. So I think counseling, as you said, is the most important thing when we are doing PGTA, and plus the additional cost. Suppose they many times they say that probably in a good, I mean, who has many embryos, you can do PGTA, so you can identify which will decrease the miscarriage rate probably. But again, the cost increases per embryo. I think they take almost 12 to 15,000 rupees. So that much cost is increased. So doing PGTA in some number and not doing in the other, really, I feel doesn't make any difference. So that's my opinion. I don't know what Kundavi has to say about it.
There was some article some years back in Australia. They had some problems, right, doing this
Yes, ma'am.
PGT, and
Even they
they've
claim
gone even to the
recently
court.
there was a case in the court, I think. Yes, ma'am.
Even in the
Claiming that.
UK, there was this thing that they didn't have consent to discard the aneuploid embryos, and the patients, requested some aneuploid embryos to be transferred, and those resulted in live births, and that created a huge
Great
cry
issue.
around.
Yes.
So, but ma'am, having said that, all your points taken, we face day-to-day, scenarios in our OPD, counseling, advanced maternal age, everything. But when a couple is not willing for a donor cycle, and sometimes when they, have, questions like, they want to know the embryo status, whether it is aneuploidy, they come well-read, advanced maternal age with the risk of Down syndrome and other things. If they accept all the possibility of no blastocyst conversion, or the possibility of aneuploidy is high, and they want to go ahead and do PGTA, then we can probably go ahead and, with all these explanations. But another scenario where, we can do PGTA is where there is true recurrent implantation failure, which is only 5%, if it is really recurrent implantation failure, and then we left with no other choice but to transfer a euploidy embryo and see. So I think definitely in those
So
scenarios.
even for that also, ma'am, just I want to add a point. Even for that also, there might be a reason in the uterine factor other
That's
than
right. That's why I said
physiological
true
factor.
recurrent implantation failure. It is
Yes.
only 2% or 3%. In
Yes.
most of the cases, we'll identify some chronic endometritis or something or the other. If it is really that, I think it's the euploidy that is really going to matter. If we
In that also, if they have a history of previous testing for products of conception, that will be fine. That will be more helpful for us.
But then in RAF, we don't have that option, right? In RPF,
RAF, we don't have any.
we don't have that option.
Yeah.
So,
Because many a times it is the endometrial factor also, because there's
absolutely.
so much of the interleukins, the cytokines, and all the other opposition factors, and so many other things in the endometrium which are involved in implantation. So basically, we cannot really say whether it is the embryo factor or the endometrial factor in patients with recurrent implantation failure. So
So
if
it is
When you
just like
have less number of embryos in a poor responder, would you still go with the blast or would you go with the cell stage, ma'am?
ma'am, I will not go with that.
no,
That's what I'm coming to say. Even for poor responder, as madam was talking about recurrent pregnancy loss, for a PGT, we need again blastocyst. As Madhuri ma'am was saying about the number of embryos to get a blastocyst, that will be high. So I will prefer either a cleavage stage transfer, or even day 2 transfer is good enough for those patients. So instead of repeatedly trying for PGT using so many advanced technologies, we can try simpler things and make the patient pregnant if possible.
And also all these studies are focusing on good prognosis patient. and not the low prognosis. So we even know don't have the evidence.
And one more thing, all the studies are even patients coming to them or not paying by themselves, it seems, right? Whether they will be getting insurance or paid by the government. So that will be easy for them, but it is not possible in our country, I feel.
In our scenario, no
I
embryo
would like
transfer is a big problem because of the financial liability and other things. So I think in a poor responder, day 2 or day 3 transfer is still the
Still holds good. Yes.
Yeah, so actually, I had a patient now recently who had come to me. So she had undergone some 2 cycles outside, and both the cycles were cancelled because they didn't get any blastocysts. So at my place, we had, and she was a good responder. So we used to get about 9 to 10 oocytes. So every time we've done a day 2 transfer, but then or a day 3 transfer, where the embryo grade was good, it was grade 1. But then the remaining what embryos we kept, they never became a blastocyst. So the third time when she said, no, we'll just go for a blastocyst transfer. But then what we saw was that most of the embryos got arrested at morula stage, and only one was a very early blastocyst. It was just cavitating, and she did not conceive. So in this patient, do you think it could be a male factor because usually the paternal genome gets activated after
Zygote maternal transition happens after day
so
3.
therefore probably it is the paternal genome which is
Contribution comes in
yeah.
on day 4 and after day 3. Yes,
Yes.
ma'am, definitely.
So it could be. So what investigation do you think we should do in this male?
Ma'am, we can't do anything as of now. I'm not for DFA also, sorry.
Yeah. I mean,
So
it doesn't
at present,
really make much difference. Yes.
yes, ma'am, definitely. It will not make a difference. And one more thing, we can try simpler methods like we are trying to improve the sperm either by frequent ejaculation. Suppose if the patient insisting on self gametes, we don't have any other way to proceed. So we want to just try with the repeated samples. That's all. The repeated IVF cycles. That's all.
Yeah, but
Why not, ma'am, why not DFI when a male person is an elderly person? And then at least we can do something in the lab, right? Like a single, when one day abstinence and the second ejaculate or something, once you know that the DFI is on the higher side.
no,
Even without testing for DFI, you can try repeated ejaculation and with less abstinence. I am for it, ma'am. Definitely that
Put in
produces.
your SOP also.
yes,
Yes.
but then this patient, I mean, every time there's an arrest only after day 4. So basically, this is a paternal genome which gets activated after that, after day 3. So I thought that it could be a male factor. Probably we can do a karyotype, see if they have any structural anomalies, and then probably, I don't know. If
Even
there's
the whole exome sequencing is now available, ma'am. Instead of karyotyping, we can use that also for test any genetic factors in the male.
yeah.
So with whole exome sequencing and karyotyping, we are thinking of, I think we can definitely add a SESA to the sperm and see whether we can do any
Ma'am, it
microfluidics
is
or
no
anything when
harm
we're
in
thinking
doing.
at that.
Definitely,
So
ma'am, it is no harm in doing.
Only to
But
know that
based
all
on
the
that, you
cause,
cannot improve the sample. That's what I'm saying.
No,
you
with
cannot improve. We
microfluidics
can
now,
only
lot
know
of
the cause and probably you can counsel then
Counsel the patient.
absolutely.
for
That's
a
all.
donor gamete. That's what. That's the
Definitely.
what we can do. I mean, the investigations are basically only for that.
Yes.
So we
You've
have
got
to
good pregnancies with morula transfers also, ma'am. We've started working on that. Morula, day 4.
Yeah, there are some people who are doing modular transfers. But initially, I mean, what we have learned is probably not to, disturb the day 4 embryo and either go either for day 2, 3, or 5 transfers. But there are now papers which have come out where they are doing day 4 transfers.
So we have to wait for some multiple approaches like a time lapse or AA or non-invasive techniques for single embryo thing. What is the view on that, ma'am?
Oh, but again, there's no evidence for time lapse.
Yeah.
There's no evidence for culture media. I mean, the non-invasive PGT. I don't think there's any evidence for any of these things.
We have to wait for some large prospective studies.
Even if you look at the ASHRAE guidelines, which is there on the add-ons, in that also they mentioned that there's no role of PGTA.
Any questions?
I just wanted to add one point. Hello.
Yeah.
Yes, ma'am.
Yeah. No, of late, even though we are freezing the embryos on day 3, we are culturing them for 1 day when they have adequate number of embryos. Even if we are not going for day 5, even a day 4, no, when we are culturing for 1 day, if it is growing, that is also improving the pregnancy rate. So we are doing day 4 transfers for some of those patients. And day 2 we have stopped. Day 3 we are doing. When there are good number of embryos, day 5 we are doing, but day 4, 1 day culturing, we are finding it is little beneficial. We are able to counsel the patient whether there is any problem in the embryo.
Yeah, so there are, especially in Israel, there are many centers who, for recurrent implantation failure, they're doing sequential transfers, where they're transferring one embryo on day 3 and they're transferring one on day 5. And what they have found is that they have improved pregnancy rates. Actually, I have not tried that, but I think Dr. Nalini Mahajan, she does try in her patients of recurrent implantation failures, and she said that she's got good results. But in Israel, many centers are doing that.
In that case, like you will be starting your progesterones also on day 3 and,
No, you start your progesterone normally as you
progesterones
start on
as
the day of
usual.
the oocyte retrieval. Yeah, yeah. Only thing is you do a day 3 and also you do a day 5.
Day 5.
So that's what they have. You're muted.
Well,
Sorry. No, yeah, I said the 2 embryo transfers.
Yeah, and in the same cycle. That is, you do
I
on
know.
day 3 and then you do on day that way.
Ma'am, I couldn't unmute. I just had a question to Madam, Dr. Madhuri Patil, ma'am.
Yeah.
Ma'am, my question was like you are doing a fresh transfer. You already have carpus luteum. We know that the functioning of carpus luteum is not efficient. But how do we say that with the vaginal progesterone only we are measuring that level? And moreover, it depends on the assay method also. And it is not going to be the constant because there will be difference in when the variations will be there. So how do we judge when there is a corpus luteum to add another progesterone based on the hormone, let's say?
So
Because in frozen transfers, we don't
cannot,
have a
we
corpus
cannot
luteum.
differentiate between
Yeah.
between the progesterone which is secreted by the corpus luteum and which is because of your progesterone
Yes.
what you're using.
Yes.
So basically,
Yeah, and there are studies which says the endometrial levels of P4 is more when we are giving the vaginal route rather than IM when we are giving the serum levels are more. So
yeah.
based on progesterone levels alone can be
So
correlate in a fresh
if you
transfer.
look at the recent studies, they were again saying that intramuscular progesterone is much better than your vaginal
Yes,
progesterone or your
yes,
oral dydrogesterone. Just recently, there are 2 studies which have been published. So they still feel that intramuscular progesterone is better. So, I mean, we
and there are
don't know
yes, ma'am.
we've not really analyzed the molecular parameters of the endometrium because basically it is we have to do it in a non-transfer cycle. We cannot do it in a transfer cycle. So when you stimulated the patient and when you're given progesterone and you're looking at we really do not know exactly what happens if you're giving a vaginal or an intramuscular progesterone and whether a more endometrial progesterone level really helps in implantation or not. Because
Yes.
if you look at the pregnancy rates are almost similar when you're using a vaginal progesterone or an intramuscular progesterone.
And one more thing, ma'am, you said about a fresh transfer in PCOS. I just had it out because we did in some of the patients, the endometrial gene expression studies, and we found those patients who received agonist protocol, they had advancement of the endometrium. So that was also one reason why we deferred fresh transfer in PCOS when we are giving an agonist
Basically
trigger.
now ERA has been outdated. So there's several papers
Yeah.
which have come which say that ERA really does not make a difference. And in December 23, there was a paper in Fertility Sterility, which was, I think it was a randomized control trial where they compared the patients and they found that ERA really does not help. And your progesterone levels on the day of your trigger are going to tell you whether there's going to be an advancement or not. If your progesterone levels are definitely high on the day of your trigger, there is going to be an advancement of your.
Yes.
But it is true that even before egg collection in PCOS, we see that the endometrium starts getting thicker. Many
Yeah.
times it is 1.2 to 1.3 centimeters at the time of egg collection. So is it worth going and doing fresh transfer in these patients?
No, but it's 1.3 and all. It really does not make, as long as your progesterone levels are low
And
on the.
maybe even polypoidal at times, you can see it. So
Yes.
even without an error test,
I,
that.
I mean, I use a very low dose in my patients, so I normally don't see. And in whichever patients, I mean, if I have started my antagonist late, definitely there is a higher progesterone, late follicular progesterone level, and you can see that they've already started becoming secretory even before you give your trigger. So in those patients, anyway, you need to freeze because you know that they've already become secretory. But many a times, what happens is if your uterus is not totally retroverted or totally antiverted and it is mid-post, then you cannot really make out the structure
Pattern of
of your endometrium. You cannot make out a triple layer because of the shadow of the myometrium itself. It looks secretly right from the beginning. So you also need to look at your ultrasound findings, wherein you need to look whether it's antiverted, retroverted right from the beginning, whether you're getting a triple line or on the day 2 or 3, you're still having a echogenic endometrium because of the position of the uterus. That also needs to be basically considered. And the endometrial thickness basically reduces only in the luteal phase. In the endometrial, in the secretory phase, anyway, your endometrial thickness is going to increase. Only once the secretory activity happens, when the progesterone is there, your endometrial thickness should reduce.
And Madhuri, there is always a dispute about doing ICSI or not ICSI. Even today, there is a dispute. So have you stopped? Have you stopped doing ICSI?
We don't do ICSI in all patients. We do only in indicated patients, at least at my clinic. So whenever the sperm count is good, we would really go in for IVF.
Because there are so many men with borderline, motility and
No, but
morphology.
what we should look at is basically at the post-wash count and motility. If the post-wash count and motility is good, still we do IVF, even if we have 2x or 3x. And many times if I find that our embryos are good on day 3 also, I do culture them, even if they are less in number, to blastocyst, and we do a blastocyst transfer.
Because I would never forget my first patient of ICSI. That guy had married the second time because the first marriage they had no baby, and with this second wife when he came, we did not have ICSI, and she had almost 8 or 10 oocytes, and we checked next day, none of them were fertilized. So when we started doing ICSI, there was a couple who came first for the first batch itself, and they did ICSI, and then the child today is so many years, 1998. And it was a second marriage for that man, thinking that it was a female factor, but ultimately it was a male factor.
Yeah, so basically that we'll know only after we do IVF if there is full total fertilization failure. But just by looking at the sperm, because I don't think we do emzo
So
more
many times it may be worth it even doing 50-50 if they have enough number of eggs, rather than waste a cycle.
No, but you can always do rescue ICSI, na? If you do rescue ICSI also, you can you get good number of embryos. I have done in a couple of my patients. But only thing is we need to freeze them because the endometrium will be advanced, because you cannot do a fresh embryo transfer because you'll not get the blastocyst on day 5, but you'll form your blastocyst on day 6.
But I do not know whether they had enough studies on the children born after these rescue ICSIs, because the number of cases are much less. And what are the changes,
But
metabolic
last children
changes?
born, I myself have had 2 pregnancies with rescue ICSI.
That is very less. Yes, ma'am. Really, it is true. The particular time you want to start rescue ICSI is very crucial. So exactly you have to see as soon as the second polar body was extruded, and you should have a dedicated embryology team for that. And we don't have many of the labs lack time lapse, and to pick up that exactly, it's very difficult for.
But normally we do see the embryos at 16 to 18 hours, na? So we would know really whether they're fertilized or they're not fertilized.
Definitely, ma'am. Even after after that 16 to 18 hours, doing a rescue ICSI, it is better to do it earlier. But we don't usually not catch up at that time.
Yeah, and if by doing a little early, if you have a triploid, you'll be really in soup. Anyway, there is no end to this discussion, but it's very interesting.
There are
Very
many
nice
points
discussion
for,
today.
for and against, against also all these things, whatever we are
We
doing.
had 2 patients with the ICSI. They had the 2 embryos transferred, each of them. And one was a complete mole and one was a live pregnancy. So, and the common reason for complete mole is a triploidy actually.
Many a times, if there is a problem in the oocyte itself, even if you do ICSI, there's failure to activation and you get total fertilization
And
failure.
both the patients had donated eggs because of Turner syndrome. So that was very interesting to have. But of course, they had a live birth. That was good end of the story.
Nice.
Great, ma'am. Thank you so much for
Thank
sharing your experiences with us. I think it got extra special journal club discussion today. We had so many nice points.
So I really thank on behalf of my clinic and my students for inviting us to present over here at the TAPISAR Journal Club.
Thank you
you,
so
ma'am.
much for TAPISAR team also. I also enjoyed the discussion very well. Discussion was very nice. Thank you so much.
Yeah, I would thank
A
Dr.
wonderful discussion, ma'am. Thank you so
Kundavi,
much.
Radha, and the team for a very interesting session.
I request
And
Radha to
Madhuri made it very
give the vote of
lively.
thanks.
As usual, ma'am, as usual.
Hey, I was so
Yeah, thank you, ma'am.
irritated.
It was a good
You won't believe I
discussion,
was so
actually.
irritated during the case presentation. That girl was presenting, she said something on pre-implantation treatment in IUI, pre-treatment in IUI patients. Then she said no hirsutism, no irregular cycles, antral follicular count, she said was 6 to 7. And they've done a laparoscopy and they have done a ovarian drilling in this patient. And they've also started on metformin and myoinositol. So I was really, I was so listening to them. And then every time she used to just go offline, she used to come online. So today my evening was very bad. So I said, at least this should be good.
But hats off to you, Madhuri. Every day you are listening to the students and trying to uplift them. That's great.
I can do anyway.
Very nice.
We hope the journal club made your day better, ma'am.
Yeah. That's what I said. It made it better because
Radha ma'am, I kindly request you to give the vote of thanks.
Yeah. Okay, it was a very wonderful session and very educative, and I thank Kundavi madam and Sindhuja for taking all the pains and organizing this. I should thank Madhuri Patil madam and Anand Lakshmi for a wonderful discussion, along with Dr. Sujata and Dr. Vasundhara. I also thank the presenters Vaishnavi and Smita and the Shield Healthcare for the wonderful platform. I also thank Mohan for the flyers and making it ready on time. Thank you, all the delegates who took part in this discussion. It was a wonderful discussion. Hope everyone is benefited by this. Thank you very much, madam. And thank also Dr. Asha Rao for taking part in the active discussion. Thank you very much. Thank you.
I enjoyed it. My pleasure,
Bye.
Dr. Radha. Thank you.
Thank you. Thank you so much, ma'am.
Bye.
Yeah. Thank you, ma'am.
Thank you.
Thank you, ma'am.
Yeah. Bye.
Good night, and all of you have a nice evening. Bye.
Thank you, ma'am.
Thank you, ma'am.